Dr. McQueen. All right. We lose Dr. McQueen? Yeah. Give it a few more seconds and then we'll.
He lives way out in Lansing and has marginal internet and I think marginal cell phone service too.
Oh.
Sometimes that's a nice thing to have.
Just like that.
Oh, I'm so sorry. I just couldn't get a signal.
Oh boy. All right, Emily, we will let folks in and we'll get started here shortly. Thank you folks for logging in. We will get started in a few moments once folks are on screen and in the session. Thank you for joining us on a Sunday evening, back-to-back Sunday evenings. Dr. McQueen is coming back on. Give it a few more seconds to let folks log in. Folks will be accessing this live, and I'm sure the recording will be viewed often, as the recordings from last week were viewed. Thank you for spending a Sunday evening with us. All right, to honor everyone's time, we will get started. Thank you for joining us. My name is Louvel Brown, and I have the honor and privilege of serving as superintendent of schools. And I'm joined with some of our community servants and experts as we are gonna engage in a conversation that we've been having for about a year. And today is a bit of an update as we talk about schools in Tompkins County and Ithaca City School District and COVID, vaccinations, and we will be taking your questions as well. Again, I'm looking forward to learning and taking some notes. We're joined by some community experts, and I'm going to just have them introduce themselves so we can capture it all. We will start with the man who needs no introduction because he's been everywhere, Frank Krupa. So Frank, if you can tell folks a little bit about yourself, and then we go to Dr. Snedeker and then Dr. McQueen, and then Ms. Talcott, and then Carrie Burke. So Frank.
Great, thanks, Dr. Brown. And for those that don't know, I'm Frank Krupa. I am the Tompkins County Public Health Director and Mental Health Commissioner. And I've been leading the county's operational response to COVID since January of 2020.
And I'm Jeff Snedeker. I'm a pediatrician and pediatric infectious disease physician at Northeast Pediatrics and Cayuga Medical Center.
Hi, I'm Doug McQueen. I'm an adult infectious disease doctor and internist and director of infection prevention at Cayuga Health System. And I've been working on this health system's COVID response and with some organizations in the community as well.
Good evening. My name is Lily Talcott, and I get to serve as the Deputy Superintendent for the Ithaca City School District. And I am also the COVID-19 coordinator for the school district.
Good evening. My name is Carrie Burke. I am the coordinator of health services and wellness for the Ithaca City School District. And this evening I'll be serving as your moderator. We have a number of questions we'll be asking our panelists here, and we'll also be soliciting your questions. So if you have things that you would like to ask those assembled here, please put your questions in the Q&A. With that, let's get started. I think, Frank, I'm going to direct the first question to you. If you could just level set for us here and tell us a little bit about where we are right now with COVID. Where are we with cases? How is vaccination progressing? And what are the trends that you're seeing?
Yeah, well, there's some good news on that front. I think yesterday was our first day under 100 active cases since October. So we're definitely trending in a good direction. We did see a holiday bump, a holiday season bump through November, December, and early January, and then our numbers started to decline. We did see cases in the higher ed student population as they returned, but fortunately our cases were going down at that time frame, so it didn't really cause a community spike. And our higher ed partners have done an amazing job of containing and controlling any students that arrive that are positive for COVID. So generally good news on the disease front. Our hospital has a couple of people in for COVID, so good news on that front as well. Vaccines continue to roll out. We've been fortunate here in Tompkins County through the excellent partnership we have with Cuyahoga Health Systems to be able to set up the mass vaccination site at the mall. And so we've vaccinated well over 10,000 people at this point with their first dose. So making a lot of progress there, and vaccine supply continues to grow a little bit at a time. So we're starting to see more and more doses each week. And we've been able to administer those in the week that we receive them every time that we do. So a couple of pieces of information about vaccines. Last week, we launched a registry. So we're encouraging anyone that is currently meets any of the eligibility criteria that the state has put forth to go ahead and register. It doesn't guarantee an appointment, but it allows us to understand demand in those different eligibility groups. And we will be using the information provided in the registry to email out and or call with registration links when the person that enters into the registry is able to get a local vaccine slot. So we're really encouraging folks to go there. And then this weekend, the big news is the state is allowing local health departments a specific allocation for 65 plus populations. So that's really good news. That was the one group that we really weren't allowed to do locally. It was only pharmacies. So we're excited for that. We're hopeful there'll be more vaccine that comes for that population. So we encourage folks to continue to monitor our webpage, sign up for the registry so they can be informed about when vaccine is available. And we're going to keep getting it into folks as quickly as we can get it.
Thank you. Thank you for that. Dr. Snedeker, I'd like to direct the next question to you. And there's been a lot in the news recently, particularly with this topic of school reopening. What have you seen in terms of the research out there about what it says with respect to COVID transmission in schools?
Well, for the most part, COVID disease in schools has been somewhat reflective of the burden of disease in the community. The good news is that when schools have been adherent to social distancing and masking and screening and measures such as that, there's been very little, if any, transmission within schools. So that's been a real bright spot. And it was something that I had some skepticism about, frankly, at the beginning of the pandemic as to whether that would be adequate to contain spread within schools. But I think that's been the case nationally, and our local districts have done an excellent job of identifying cases, contact tracing, closing when they need to. There have been a variety of measures that have been in place. So there's been very little, if any, sustained transmission in schools. Thank
you. And so, Frank, I'm going to come back to you if I could. If transmission is not typically occurring in schools, or we're not seeing outbreaks tied to schools, then why are schools, it seems like, continuously closing?
Sure. I think the biggest factor was the quarantine of individuals that might have been exposed. So last semester, we were quarantining entire classrooms if there was a case. And we were using a relatively short time frame of proximate contact. So beyond the 6 foot 10 minutes, if folks were around a positive case for an extended period of time, we were quarantining them as well. And I think in a lot of instances for school districts, that meant adults. And so because the teachers and the other support staff were in quarantine and weren't able to be there for the children in school, it made it difficult to remain in person. The schools, we did not, as the health department, close any schools because of COVID cases. Well, except for back in March when this all first started. But once schools reopened in the fall, it was really school districts making decisions based off of the people that were impacted by isolation and quarantine. We have relaxed that guidance. And so we're now requiring an hour or more of contact with an individual beyond the 6 foot 10 minutes, right? If you're 6 foot 10 minutes, that's an automatic quarantine. But for someone like a specials teacher, like a librarian or a music teacher that came into a classroom, if they were only there for 45 minutes, we wouldn't be quarantining them now. So that was a shift in our guidance that I'm hopeful is going to help the districts continue to stay in person more than perhaps we were able to in the fall.
Thank you. Lily, I'd like to turn to you now as the district COVID coordinator. Can you give us some insight into what determines whether an entire school building is being closed or just a classroom is being shifted to distance learning? And I should say, we're talking about building closure. Learning certainly continues.
Yeah, I think Frank summed it up really well. It definitely has a lot to do with staffing. Timing makes a big difference as well, as does our knowledge of the individual's schedule and the contacts that we can quickly discern. So for example, we might learn at 7 o'clock in the morning, true story, that someone was positive. And when we looked at the individual's schedule, we determined that it would behoove us to have the entire school shift to distance teaching and learning because of the number of folks that they may have come in contact with, right? And that then permits us time to very carefully go through the support the contact tracing process with the Tompkins County Health Department, right? So we provide names, phone numbers, you know, the length of time that folks were in contact with one another, et cetera. If, on the other hand, that we learn, say, on a weekend that an individual is positive and we can we have more time in order to determine the number of close contacts, then we may just shift a few folks to distance teaching and learning, and the remainder of the school can continue in person and distance. So it really depends. Each case is very different, I would say, and the timing, the number of contacts, and of course, staffing, as Frank expounded upon. I don't feel like I have to repeat that, but that's really what it comes down to. If we have a large number of folks who are in quarantine, we simply can't safely staff the building. And that, frankly, has been what it's come down to most of the time.
Thank you. Dr. McQueen, I'm sure you're aware the health department's been running clinics designed to increase access to vaccinations for those who work in schools. Can you talk a little bit about what it means to be fully vaccinated, what the implications of that may be for our staff?
Sure. So we can go a little bit based on what the trials that studied these vaccines that led to their approval, what insight we got from them, which is that if you received two doses of the original either Pfizer or Moderna vaccines, that 2 weeks after that, you had something like a 95% lower risk of acquiring COVID in the coming months after that vaccination. There's a third vaccine approved this weekend, the Johnson & Johnson one-shot or one injection vaccine that had similar numbers. It had tested, though, in other countries, including South Africa, where the numbers were a little bit lower. The percent decrease in risk of acquiring a COVID infection was not quite as good, but still very good compared to Pfizer or Moderna. The other point I would make about all of these vaccine trials is that the people who received the vaccine had a very low, almost 0% risk of becoming extremely ill or dying compared to those who didn't receive the vaccine in those trials, even in areas where there were other strains of this virus circulating. So I think what it tells us is that, at least for the remainder of this semester and hopefully beyond, that people who've had the vaccine have a very low chance of becoming infected with COVID. And really, if they do become infected, it's likely to be a very mild illness.
Thank you. Frank, I have a question for you. Are there, how will, for example, quarantine or isolation be handled differently if we have staff members, for example, who are exposed to someone with COVID but are fully vaccinated?
So we are now following CDC guidance for close contacts with vaccinated individuals. So if you're post 14 days from your second dose, as Dr. McQueen just identified, that's when we consider you fully vaccinated. And for 90 days thereafter, you would not need to quarantine as a close contact. So hopefully that will also help with your educators and other staff, that if they are fully vaccinated and there is an exposure in the school, they wouldn't necessarily need to quarantine once they're fully vaccinated, at least for 90 days, which hopefully will get us to at least the summertime.
Dr. McQueen and Dr. Snedeker, as our infectious disease specialists here, can you talk about for those persons who are vaccinated, you know, there's been conversation about what they can and can't do post-vaccination once they have reached that fully vaccinated status. Could you highlight some of those things? Why are we being asked to continue some of these behaviors and mitigation strategies?
Yeah, it's a great question. You know, we have excellent data that the vaccine protects against disease. There is less data that the vaccine reduces the risk of passing the illness or passing the virus on to others if you have a mild infection or infection without symptoms. The research that was done in animals before these vaccines were put into humans suggests that the vaccines do protect against transmission, but the human data just isn't there yet. And so until it is, the CDC is being pretty cautious. People who are vaccinated should continue to wear masks and observe social distancing. The risk of getting COVID if you're vaccinated is not zero. It's just way lower, and the risk of getting severe infection is way lower. But you don't want to run the risk, if you can avoid it, of getting mild illness that still might be transmissible to others. The CDC guidance on the change in quarantine, if you're vaccinated, is a bit of a leap of faith, frankly, based on the animal data. Because the human data isn't there. I think part of the reason that guidance may have been given is that it's pretty strong incentive for people to be vaccinated. And I think, you know, I think a lot of people were hesitating to get vaccinated on the theory, well, if I get vaccinated, I still have to do all this stuff, so why bother? That's a good reason to bother. And I think it's very likely that that will be supported by human data in the end, but at the moment that, you know, 100% confidence in that is not yet present. And that's why they're still recommending masking and taking the other distancing measures that are still recommended.
Dr. McQueen, is there anything you'd like to add?
Nope, I agree with Jeff on that.
So speaking of vaccination, do we have any sense or timeline of when there will be a vaccine available for children?
It depends on what age range you're talking about. So right now, no vaccine studies have been completed in children. So data on safety and effectiveness does not exist. There's no reason to think that the vaccine should behave differently in children compared to adults. But until those studies are actually done, the FDA will not license the vaccine for use in children. And one of the differences is the concern about the multisystem inflammatory disorder that can rarely be triggered by COVID in children. They want to make very sure that the vaccine itself does, or any of these vaccines, do not trigger that reaction in children. There's no biological reason to think that they should, but in order to be confident of that, you have to have actual numbers. Right now, studies are well underway in children 12 and up. A number of those studies for Moderna and Pfizer are fully enrolled, and they're now following the children who've been vaccinated to look at their rates of developing disease, to look at side effects, to look at their antibody responses, and so forth. And my guess is that results from those studies will probably be available in April or May. So there could be an FDA decision as early as the summer to allow children 12 and up to be vaccinated. For younger kids, probably those studies aren't going to begin until the studies in the 12 and up children are completed. And so that pushes the timeline way back for younger kids. I think it would be optimistic to expect that children under 12 will be able to be vaccinated before early 2022. It's possible that could happen, but I think realistically, it's not going to be until next year for studies of that type to have been completed and for the FDA to have assessed the evidence.
Thank you for that. So with respect to vaccination, and I would appreciate both the public health perspective, Frank, if you could weigh in, and our infectious disease experts. We've been working our way through these priority groups. What about persons who are not in a high-risk category? Why should they be vaccinated at all, particularly if they are likely to only experience a mild course of illness?
Yeah, I think we've touched on it with several of the other questions. It's about protecting others. There will be some people that can't be vaccinated because of contraindications to the vaccine. There will be folks that are vaccinated that are still susceptible. That no vaccine is 100%. So our goal is to achieve what we call herd immunity, is to have enough people that are vaccinated in the community or have immunity to the virus, so that way it has nowhere to go, right? So if somebody is introduced into the community that has COVID, if everyone that they bump up against COVID can't be transmitted to because they are protected, then the virus will die because it has no host, nowhere to go. And that's really what we're trying to achieve. So when we ask everyone to get vaccinated, it's to try to achieve that herd immunity to protect those amongst us that won't be able to, and those for whom the vaccine won't be 100% effective.
Yeah, it's important to recognize too that there's a gradient of risk, particularly with respect to age. So, people over 70 have been identified at significantly higher risk of COVID complications, but it's not like, magic if you're, 69 and a half that you're not at risk. So the risk actually begins to increase a little bit over age 30, and then it keeps creeping up from then, and it becomes, quite substantial as you get into the older age ranges. As it happens, my wife is 64 and a half. She has no risk factors, so she can't get vaccine until August, and she's frustrated because she's right on the cusp. And I think a lot of people are in that situation. So, everybody in the population can potentially benefit from being vaccinated because the vaccines are so safe. So there's no reason not to get as many people vaccinated as possible, both for individual benefit, which is certainly greater if you're older or have risk factors, but also for the benefit of containing the infection for those who can't be vaccinated or for those whom the vaccine fails to protect, as Mr. Krupa indicated.
I would just mention that we have this discussion about herd immunity, and a few months ago, it seemed like herd immunity was a bad thing, as a patient pointed out to me. But it's not. The thing that was bad was how we get to herd immunity. The question that was in the media a lot was, well, why don't we just all get infected? In some Scandinavian countries were trying this. Why don't we all get infected so we'll all be immune? The problem is, if the mortality rate of this illness is something like 0.5% of the people who are infected, a lot of people would die to reach that point. And it's also not clear that mild infections provide you much immunity. So the idea is that we can reach that herd immunity point by vaccination. We may need some boosters down the road. We may need some modifications of the vaccine to provide better coverage against other strains, or if some duration of the immunity starts to fail or to decrease over time. But generally speaking, the idea is we'd like to have herd immunity be attained through vaccine and immunization.
For those who have access to the New York Times, or for what of the Times is available publicly, there was an excellent article a little over a week ago running simulations on, how long would it take to get to vaccine immunity if different levels of the population got vaccinated as opposed to having disease itself. And the difference from getting to herd immunity via vaccine compared to through natural infection is hundreds of thousands of deaths. So there's absolutely no question that the best way to get to herd immunity is through vaccination.
Thank you. Lily and Frank, I'm hoping you can talk a little bit about, for people who may not be aware of what the district has been doing, what the county's been doing to really facilitate the vaccination process for staff.
Well, I can start for the county. So when we first got vaccine late December and early January, we were early. And because of our partnership with CHS, we were able to get 1,800 doses a week for 2 weeks because nobody else was vaccinating yet. And so thankfully, we were able to get that early start. But if you remember back then, it was kind of we put a link out and it was, battle of the fittest to try to get an appointment. And that's kind of how it is with the state sites now. And there's a lot of frustration that goes along with that. So the path that we decided to take here locally was to begin to prioritize within the state priority groups. So health departments, up until just recently, all we were allowed to vaccinate were people in phase 1B, essential workers. And so rather than have it be a free-for-all every week with several thousand people trying to get a couple of hundred doses, we decided to prioritize within those groups. And so we've methodically worked through the different occupations that were in phase 1B. We got to educators fairly quick because we knew that was one of the biggest groups that we had in phase 1B. And so we're actually on week 4 of prioritizing a portion of our 1B doses for educators and the education, so folks that work in PK through 12. So the way that we did that is we worked with the school districts, all the school districts in the county, as well as the private independent schools with their leadership. And they all got a link from the health department that was embargoed to a certain time. And then they all released it to their employees at the same time. And at that same moment, I added the appointments into the system. So in theory, at least in that smaller group of people, they all had an equal chance of accessing the link. Now, we knew there was way more people than links. In fact, they disappeared in 3 minutes, 4 minutes, and 5 minutes the first 3 weeks. So we knew the demand was far outpacing our supply, but at least it was a few thousand people versus perhaps 10,000 people all clicking for those 300 appointments. This Saturday, we allocated a large amount of vaccine to the districts, and I think we've made some significant inroads. We will continue to work with the districts and make vaccine available until we've feel like we've saturated the educator population. But that's the approach that we've been taking to try to add some structure rather than having everyone clicking all at the same time.
Just like to sing Frank and his team's praises. You've really done an exceptional job, I think, given the incredible supply and demand challenge that we've all faced right now. And the school district itself, of course, we've continued to collaborate very well with our union leadership to ensure that we have ample time for our educators to leave work during the school day if they need to in order to receive the vaccine. And then per dose, 3 days of recovery time that is that they do not need to use benefit time in order to take, right? So we know that folks have been having some difficult reactions to the vaccine, and we want to, of course, be really mindful, and we want to eliminate as many barriers as possible for our colleagues in the school district in order to ensure that they can be vaccinated.
Thank you. For our panelists, anyone is free to answer this who has knowledge. Do we have any sense of what the timeline is for populations who are outside of the current priority groups? When can, sort of, for example, your wife, Dr. Snedeker, or others in the general populace have access to vaccination?
Well, my crystal ball is a little fuzzy, but I'm an optimist. I actually think it's quite likely that by early summer, vaccine will be available to anybody who wants it. I think that's going to depend on a number of things happening between now and then. But the approval of the Johnson & Johnson vaccine is definitely a positive step because it really depends on supply. if supply is limited, then obviously you want to target the people that are at highest risk. But the bigger the supply becomes, then the more it becomes possible to open it up to the general population. And I can't forecast exactly when that will be, but I'm very hopeful that by the middle of the summer, the vaccine will be, or one of the vaccines at least, will be generally available to people who want it. There may not be enough going around for people to choose one or the other. And right now, there's not a strong basis for preferring one vaccine over the other. They all seem to be highly effective, and so far with pretty good durable immunity. So hopefully that will be the case, but that depends on a number of things going in the right direction between now and then.
Yeah, and we're all kind of guessing at this point. I guess it's educated guessing because there's so many factors that play into it. We don't yet know how much Johnson & Johnson will be available, and to what populations it'll be prioritized for. I agree with Dr. Snedeker. I think it might even be a little sooner than that, just because, quite frankly, we're going to switch from the problem of not having enough vaccine for everyone that wants it to having vaccine and needing to work to help move folks that are hesitant over to the side of getting vaccinated, right? In order to get to that herd immunity number, it takes almost all of us that are eligible and able to get it without contraindications to get vaccinated. So I'm hopeful in the next few months, we'll start moving closer to where it is available for anyone who wants it. And I would imagine by early summer, it will be widely available, and we'll have shifted modes to trying to work with removing barriers, making it accessible to everyone who wants it, educating about the safety and effectiveness of all of the vaccines, and really working to move those folks that might be hesitant to the vaccinated side.
And I'm very hopeful that the number of places that one can get vaccine will be much better by then too. That we won't be limited to state vaccination sites, but that you'll be able to get it from your pediatrician or your family doctor or your internist, and from any pharmacy, and that there won't be long waiting lists and complicated signups. So I think we'll get there. It's just a matter of time, and it's hard to say exactly when, but certainly there's been substantial progress in that direction.
I just want to also weigh in on that point that Jeff mentioned earlier, as to if you're facing the question, this vaccine's available today, should I get the other brand? The answer is, if it was me or my loved one, I'd recommend getting whatever vaccine was available to you at that time, that there's no real good reason to wait for a different company's vaccine to come around, that having some measure of protection is the right way to go. And in the end, we don't know exactly what the right answer is for these different sets of vaccines as to which one's the perfect vaccine. Just go for any of these that are available.
Thank you. Dr. McQueen, I'm going to direct a question to you on that topic. As I think some folks may be aware, the FDA just approved the Johnson & Johnson vaccination, but that's just one shot. And there's been a lot of conversation about it as compared to the Moderna or Pfizer options. Can you elaborate on, again, your point that the best vaccination is the one that's readily available?
Sure. So that Johnson & Johnson vaccine was studied with a one-shot dose. The Pfizer and Moderna were studied with 2-shot doses. They don't know for sure what the protection is after one shot if you never get the second one. We know it's good. A couple weeks after the first one, it's something like 40 to 50% decrease in risk of illness from COVID. 2 or 3 or 4 or 6 weeks later, it may be just as good as this Johnson & Johnson one. So in other words, there's no strong evidence to suggest one is better than the other. It may be that a year from now, all of these are given in a one-shot series as your first pass, but to be determined. There are advantages to the Johnson & Johnson just based on logistics. It's operationally easier to put together a vaccination clinic using that one because it doesn't require freezing to store it. It's one shot. It doesn't have to be diluted. So it's much simpler. So I think it'll help get the vaccine to a lot more people. It may allow taking the vaccine to people as opposed to what we're doing now, which is asking people to come to us for a vaccine. And that's just based on the way the operationally, it's been the best way to distribute as many as possible. But as was mentioned, once we start getting more and more supply and we have a smaller percentage of people who haven't been vaccinated, a lot of those people will still be the people who are at highest risk of illness, severe illness from this disease, but for various reasons haven't been able to, because of difficulty with technology or transportation or concerns about the vaccine itself, may not be able to choose the vaccine, may not be able to get to the vaccine. And so I think ideally at some point it's that we start thinking of ways to bring the vaccine to them. And I know the county's already been working on those sorts of efforts.
And I would add one thing,
Thank-
which is that the duration of protection from all of these vaccines is still not known. You know, we know that the duration is good based on the timeline that we have so far from when those original studies were done. But we don't know if durable immunity is going to mean protection for months or protection for years. We don't know anything about whether boosters will be required, and if so, how often might they be needed. Those are all unknowns. Answers to those questions will come because the people that were the original vaccine recipients in all these studies are still being followed. And so how well the vaccine continues to perform is still under study, and more information about that will accumulate as time goes on.
Thank you. The next few questions are a little bit of future casting. Some things I appreciate you may not be able to answer, but what mitigation strategies do you foresee continuing into the fall?
That is a good question. I think we can probably expect mask wearing is with us for a while. We're going to be using that as kind of the last thing that would probably go away from the public health interventions that have been in place. I think we're always, from this day forward, going to be asking people to monitor their hand hygiene and you stay home if they're sick. Those are all things we should have been doing anyway that we just, quite frankly, weren't very good at. And that's why things like the flu and others, spread throughout our population. So that will likely be with us. The social distancing and the density reductions, which I think are really what folks are most concerned about. And I know certainly in schools, the density issue is one of the biggest challenges. I don't know. I'm hopeful that we'll begin to see some evolution from the CDC on some of that guidance as we learn more about how the vaccine is working in our community, as we learn more about these new variants that are coming as well. And really the ebb and flow of the disease, right? We saw last summer, at least here locally, our disease numbers were very, very low. And then in the fall, they started to pick up again. So some of it will really depend on how the disease evolves. But I think there's a recognition, as Dr. Snedeker said earlier, that there currently isn't a lot of transmission happening in pre-K through 12 schools. Now, we could say that's because of all of these things that we've put in place, and that is certainly true. But eventually, the question it has to be posed about what is the risk versus reward of continuing to have so many students be virtual. As the public health director, obviously, I have a responsibility to deal with the COVID response, but there's a lot of other public health issues being exacerbated because of where we are. I said that wrong word. I should never use it. I always get it wrong. Exacerbated. And I'm with educators too. There's a lot of other public health things that are being impacted because of the interventions that we've put in place. Mental health, right? Food insecurity. These things that we have concern about pre-COVID are only worse now. So at some point, we have to make sure that we're evaluating the totality of the impact of what we're doing from a public health perspective. And I think we're approaching those points where decisions will start to be made on changing or relaxing guidance as we know more about how the vaccine is going to work and the disease is evolving.
Hopefully Frank's former English teacher was not on the call. But my son is a third grader at Caroline in Ms. Kostiniak's class. So shout out to Caroline and thanks for all the hard work you're doing there to let my son be in school. But what he said to me a while back was about the masking question is, why would I ever want to go back someplace and let people cough in my face without wearing a mask? So even though eventually more and more of us will be vaccinated, I think a lot of us will be used to gathering, maybe in larger numbers than we are now, but probably still using some of those other precautions like.
I think Frank's use of the word exasperated was actually perfect. You know, we are all exasperated with COVID precautions, and, you know, we want things to go back to the way they were. We're probably not going all the way back to the way things were. We've learned a lot through this pandemic about the impact of infection control preventions. I think the critical questions will be, what are the things that remain impactful without causing tremendous societal disruption and contributing to mental health issues and all of the food insecurity issues that we've had before. We have to remember that before COVID ever happened, between 15,000 and 50,000 people died of influenza every year in the United States. And that was accepted somehow as okay. But maybe there are ways that we could have reduced that burden without shutting down businesses and without, all of the economic disruption that we've had by taking some simple public health precautions. And so I think now that we've been through this experience, certainly while precautions are going to be relaxed, I think there are some measures that have been put in place that will likely be retained going forward. And I think it makes excellent sense to do that.
I agree. Absolutely. Well said, everyone. And I know the question that we get over and over in schools throughout our county, the state, and the nation continue to get is really at what point can we open up in-person teaching and learning for all students, right? And I think each of the experts on the panel this evening spoke to each of the factors, right? We talk about layers of Swiss cheese often when we talk about disease spread mitigation, and physical distancing right now, that layer of Swiss cheese, in addition to hand hygiene, practicing good respiratory hygiene, staying home when you're sick, cohorting, et cetera, right? All of those things, surveillance testing, et cetera. Physical distancing is one of that is the determining factor right now in terms of welcoming students back to in-person learning. And until that shifts at the state level, we are beholden to those rules, those guidelines, those requirements, right? And so some of you may have noticed that the World Health Organization has indicated that 3 feet of physical distancing is appropriate, whereas the CDC is saying 6 feet. Our New York State Department of Health is still continuing to ensure that there's 6 feet of physical distancing. And so there are a number of educational organizations at the state level and at the national level that are advocating for some shifts with additional mitigation strategies. I'll also add that there has been, with the CDC reopening guidance, a great deal around ventilation, right? And in-school ventilation, ensuring that that's working properly, and some really clear recommendations around that. I feel exceptionally grateful that we have been partnering and continue to partner with Train in order to make sure that our ventilation systems are in full working order. Our MERV 13 filters, we change out regularly as per the schedule. I think Dr. Snedeker, the last call he was on, he indicated that our filters are better than the ones at Northeast Pediatrics. I don't know if that's still true, Jeff, but so I think that's another layer that, again, of the Swiss cheese that I feel confident about. So if we shift one of the layers, that's, I'm not a public health expert, but that's just something for folks to be aware of.
So in defense of Northeast Pediatrics, I have to say that, we still have no, filtration going on in our office air supply system or ventilation system. But the difference is that we have, relatively brief encounters with patients. We're with them for 5 or 10 minutes. We're not sitting in the room together for an entire day, in which case the ventilation issue becomes far more significant. So as you say, the devil is in the details. And there's a lot, it's clear that there are micro environments where transmission of COVID can occur over distances much greater than 6 feet. And so there are lots of things that go into those sorts of determinants. That's like an average best, but it's not like the only possibility. So it's important to look at all of those individual classrooms, individual rooms, how much time are people spending in them, how close is their proximity. All of that goes into decisions about ventilation and circulation and potential exposure.
All right, we are at our time. I just wish to say thank you for panelists for bringing your expertise to this space. Each time we are in the space with you, we learn something. Each time we're in the space with you, we feel better about the work that we are in together. So just thank you for being here. Thank you folks for tuning in on this Sunday evening. Thank you for tuning in whenever you tune into this session throughout the week. A lot of valuable information was shared this evening. So thank you all, and hope you continue to stay engaged with us as a school district and as a county as we work to take on this awful pandemic. Thank you all.
Well, thank you in return for all of the tremendous effort that you've put into trying and ensure safety for all of our students. It hasn't been perfect, but it's always been well-intentioned, and it's important to acknowledge the tremendous amount of time and effort that's been put into this. So thank you all very much.
Thank you. All right.